Good evening, friends. Welcome to Tuesday's masterclass from Department of Critical Care Medicine at Yashoda Hospitals, Yashoda Hospitals, in association with ISCCM Hyderabad chapter. This is most sought after because across students looking at this because senior seasoned examiners are involved for the topics of discussion. So today we have two senior seasoned examiners, Dr. Saroj Prushti sir, who is head of the Department of Critical Care Medicine at Differential Hospitals. So he's with us today. Good evening, sir.
Yeah, good evening.
Yeah, and Dr. Ramesh is the head of the Department of Critical Care Medicine from Continental Hospitals, Hyderabad. So today's topic of discussion is subarachnoid hemorrhage. I think most of the day in, day out, we will be seeing as a critical care physicians and topic of discussion across all examinations, including IDCCM and FNB and DRNB right now. So basically, for this discussion, we are having two students with us, Dr. Srikanth and Dr. Shilpa. Both are DRNB critical care medicine students from Yashoda Hospitals, Malakpet. So Dr. Shilpa will be presenting the case. So Shilpa, you are good to go. Yeah, please start the case. Thank you.
Good evening all. Today the discussion is a subarachnoid hemorrhage. I'll be presenting the case now. Can you please? Yes. Next slide, please. Yes. Here is a 33-year-old female patient came to the hospital with complaints of headaches that is since 2 days, which was diffuse in nature and which was not subsided with medication, which were sudden in onset. And then the vomitings of around 2 episodes containing food particles since 1 day. And then she had a seizure-like activity, which is like stiffening of the hands, drooling of the saliva associated with tongue bite. And excuse me, this is not here actually.
Okay.
She has one episode like this, and which was lasted for about 1 minute and followed by loss of consciousness, which lasted for about 5 minutes. And on brief history, there was no seizure disorder previously, and there was no history of fever, cold, or neck pain. There was no ear pain or ear discharge, and there is no history of trauma. There is no history of drug intake. Next slide. Coming to the past history, there are no similar complaints in the past, and she's a known hypothyroidism case that is since 5 years, and for which she was taking thyroxine tablet 25 micrograms per day. Her personal history is insignificant with 2 children, and last child being around 6 years of age, and family history, nothing significant. Coming to the general physical examination, airway breathing circulation, her airway is patent with a respiratory rate of around 20 breaths per minute, maintaining saturation around 96 on room air with equal bilateral air entry, normal vesicular sounds, and the circulation BP is around 130/70 with a heart rate of 90 beats per minute. There are no murmurs. GCS is around, she's drowsy but arousable and obeying commands. Pupils bilaterally 3 mm equal and reacting to light. She's moving all 4 limbs and there are no focal deficits. Next slide. Temperature is 99 degrees. Coming to the vitals, temperature is 99 degrees Fahrenheit, and her blood glucose levels are 190 mg per dl. There is no pallor, icterus, cyanosis, clubbing, or lymphadenopathy or pedal edema. Her BMI is around 29 kg per meter square. Her ABG is normal with slight acidosis, and with lactates being 4.6. And at this point of time, my provisional diagnosis would be a hemorrhagic stroke or it could be cerebral sinus venous thrombosis, or it could be a meningitis or migraine, or any space occupying lesion.
Okay. So now, based on the history, these are all your differential diagnosis. Suppose if you think that it is a case of CSVT, so what are the histories you want to take in terms of like personal history or any other drug history specifically you want to ask?
So since
Yes,
she is in the reproductive age group, she might be on oral contraceptive pills intake, sir. Any recent change in the drugs or recurrent intake, this history we have to take it.
Okay. So thinking in terms of madam motor examination, no, you have you examined for cranial nerve examination?
she's drowsy, sir, not cooperative. Cooperative to examine cranial nerves. Could not.
So if you think that it is subarachnoid hemorrhage, are there any cranial nerves which is involved specifically in this case?
The third and sixth cranial nerves are mostly due to raised intracranial pressures are most commonly involved, sir.
Okay.
But in this case, the pupils being normal, so we did not suspect raised intracranial pressure, and there were no lateralizing signs.
Suppose if she presents with a ptosis or something like that, like what cranial nerve is involved or what is the mechanism of that in case of subarachnoid hemorrhage?
Case
Am
of
I audible?
Yes,
Yes,
sir.
sir.
Okay.
This especially
In
the
posterior communicating aneurysms can involve the brainstem involvement, can involve the third cranial nerve. Sir. We can suspect in these cases.
Okay. So any importance of family history in this case?
yes, if any family members had a similar history of intracranial hemorrhage or seizures, then we must, because some familiar disorders can also associated with this vascular malformations.
So looking at your provisional diagnosis, any like fundoscopy will help in which all conditions in this case in all these differential diagnosis?
Fundoscopy will help us if to any like papilledema features to look for toxic encephalopathy we can rule out. At the same time, due to hypertension disorders, or maybe due to raised intracranial pressures due to any space occupying lesion, or due to meningitis itself. And
yeah, CSVT will have like papilledema, no? Significant amount of venous congestion and papilledema we can easily make out in fundoscopy examination. Even in case of SAH also, if there is a rise in intracranial pressure, we can make out with papilledema, presence of blast papilledema. Okay. So go back to your history slides. Okay. Suppose if she has a history of headache prior to this, is that a warning sign for you?
Yes, sir. It can be. Yes, sir. It can be a sentinel headache. It may be there may be small rupture might have happened by spontaneous closure. Again, before the event, it can indicate that the sentinel event might have happened earlier.
Okay, so sentinel bleed.
Yes, sentinel.
Okay, so what is Ottawa scale?
When
Is there
patient
any symptoms which will have high suspicion of subarachnoid hemorrhage in your case? What are the symptoms which will tell us that this patient has a high suspicion of subarachnoid bleed?
The headache, which is severe in nature, most commonly described as thunderclap headache, and which was abrupt, and then associated with nausea, vomiting, and seizure activity is most commonly associated with due to irritation of the intracranial meninges and
rapid change in the sensory.
So any deficit, neck stiffness, not able to flex the neck, all these things will come in that, no, which has high suspicion, which will raise high suspicion towards SAH.
Yes.
Okay.
basically this nature of the headache is very, very important. So as you told, means your description for headache also, you need to describe whether it is a continuous headache or intermittent headache, that is also, and the severity and maximum headache reaching within 1 hour. That is also very important for this thunderclap headache, as you told. So it's maximum, that is also, it is a part of the your whatever scale means. So different parameters are there. So from that parameters, you can come to have that yes, patient is having high suspicion for a subarachnoid hemorrhage. So you can go for a different investigation after that. Even neurological examination, when you are presenting a neurological case, detailed examination is important, because either a motor examination, cranial nerves examination, level of sensorium, GCS, all these things, detailed examination is necessary. So in the neurological examination, what are your positive findings?
My positive findings are at this point of time, she doesn't have any positive. She's drowsy, sir. Mild confusion was there. Otherwise, she was obeying and oriented to time, place, person, and there are no focal deficits at that point of time.
So no neck stiffness, no neck rigidity, or no neck pain, nothing.
She was continuously complaining of only headache.
Headache complaint was there, but neurological signs, nothing was there. No significant
Yes.
pain.
Yes.
So what is your provisional diagnosis? First provisional diagnosis, how you think of?
It could be like intracranial hemorrhage, or it could be CSVT, sir, which comes first in my mind, considering the age and ruling out the infection cause and other intoxication.
No,
Then comes the space occupied lesion. Sir, sorry, sir.
Intracranial hemorrhage, why you are thinking?
I mean to say subarachnoid hemorrhage due to spontaneous or aneurysmal ruptures. Due to the presentation like a headache and vomitings and seizure, which was sudden in onset and then involving the sensorium, decrease in the sensorium, but she doesn't have any infection related history.
Okay, blood pressure was normal.
Yes.
Blood pressure was normal.
No. Yes.
So will you find in hemorrhagic strokes blood pressure, normal blood pressures?
No, sir. Usually we find either the history of hypertension or some associated comorbidities, and
with high blood pressure at the time of initial examination in hypertensive hemorrhagic stroke.
And the level of sensorium and neurological deficits, usually if any patient is having a bleeding, intracranial bleed,
yes,
cerebral hematoma, or usually they will have a focal neurological deficit,
yes,
with altered sensorium. So neurological manifestation may be significant at the time of admission. Okay. Okay.
Why you asked for ear discharge, ear pain and all?
To rule out any foci of infection to cause meningitis.
Medication, what medications you are having in mind?
If she has if she is on any medication, any overdose of any pills, like suicidal tendency also, since she's a young female, so we tend to ask.
Okay.
Maybe
Next slide. Any medications which will cause seizures and headache?
If taken in overdose, you mean to ask?
In the examination, you told about blood pressure, no? Is there any importance for upper limb and lower limb blood pressure separately in this case?
Yes, sir.
In aortic dissections, there can be differential pressures in the upper limbs and lower limbs. So this can.
How is it related to this? So will that present as a headache?
Neck pain, sir. more of
So,
neck
the,
pain and
coarctation of-
dissecting chest pain.
Okay. Coarctation of aorta will be associated with some amount of aneurysmal bleed and all. So that's why upper limb and lower limb BP is recorded, and differentiation of that upper limb and lower limb should be appreciated. And any importance of murmurs in this case? In your written, no murmurs heard. If there is a murmur, what you will suspect?
Any regurgitant lesion, any thrombotic phenomena, we should suspect. Sir.
She might be having some valve replacement or underlying heart disease. She might be on some antiplatelets or anticoagulant drugs, which can cause some intracranial bleed. That can be give a clue.
Very good, very good. So based on that, if the patient is having some murmur, valvular heart disease can prone for infective endocarditis also. That can also cause some myocardic aneurysms, causing bleed in the brain.
Yes, sir.
Okay. So disability, why this like motor examination? Based on this, what information we'll get? Like GCS scoring, at what point of time we have to take airway is patent, you told, no secretions, no aspirations. What point of time where you have to intubate the patient in any CNS case?
If patient GCS is less than 8 and she's unable to protect airways, or in case abnormal breathing pattern associated with low GCS, and if associated with hemodynamic instability, and if it is post-seizure, if she's maintaining the airway patency or not, because they will be in post-ictal confusion. So we first look for the airway patency.
Okay.
And any secretion, she would not be able to maintain the airway, might lead to aspiration.
So suppose if you consider this as a subarachnoid hemorrhage, what is the importance of family history? I asked this previously also. Is there any conditions which will come in families with aneurysms?
AV malformations and moya diseases.
Collagen diseases associated with collagen disorders,
Collagen
they are
disorders.
more prone for aneurysm formation.
Yeah, Marfan syndrome, Ehlers-Danlos syndrome, pseudoxanthum, all those things. And usually familial will have multiple aneurysms in the brain. You know?
And even
Okay.
sometimes polycystic kidney disease also sometimes can happen.
Polycystic kidney disease, yeah. Next slide. What is central fever? Temperature is 99, you written, no? Since it is a CNS case, you should know about central fever.
Central fever, it is mainly the diagnosis of exclusion, sir. When after ruling out all the common causes of fever in the ICU, whether it is new onset or the patient is admitting with the fever, after ruling out, and then if there is a lesion that is involving the hypothalamus, then we can contribute the fever to central origin.
Okay. So you mentioned lactate as 4.6. What could be the reason for that?
Here we are thinking that it might be due to for a seizure activity, which was generalized tonic-clonic in nature. So we thought it could be due to that. Or we should rule out, since she has a high GRBS, we should also rule out urine ketones, which was found to be negative. So it may be due to lactic acidosis, due to seizure activity.
Okay.
Next.
So the baseline investigations which we send are a complete blood picture and the coagulation profile, and liver function test and renal function test, and the random blood glucose and HbA1c, serum TSH. And she was first we have taken her to non-contrast CT brain after taking out the blood samples, and then later period we have planned for MRI brain with contrast with MRA and MRV, and ECG 2D echo were done, sir. EEG after coming to the ICU was planned. Next slide. For 2D echogram, ECG suggestive of T inversions in 1 and AVL with RBBP pattern, with tropoid being positive, and 2D echo revealed there was a regional wall motion abnormality with the moderate LV dysfunction with the ejection fraction of 40%. That's it. These were the positive findings, the ECG and 2D. Next slide, please. MRI is suggestive of subarachnoid hemorrhage, and which was minimal IVH in bilateral occipital horns, acute ischemic changes, and a ruptured aneurysm. There was an absent A1 segment in the right ACA. Next slide, please.
We are presenting the investigations. No, first we'll come with the basic investigations like blood tests.
Yes.
And then we'll go to the basic non-contrast plain CT scan and then to the MRI. No?
And so why you did MRI for this patient?
Sir, initially we have taken a CT, sir, which was normal. We did not find significant changes. So we and then there was then the history of headache was since 2 days. So we thought doing an MRI will help us in this case, because if CT is very good, if in case of like subarachnoid hemorrhage, if we are suspecting in the initial 12 hours, the sensitivity is 95 to 100%. But if it is 24 hours, again, the sensitivity comes down to 93. And again, after 5 to 6 days, the sensitivity goes down to 63%. So then we also suspected for her CSVT. So we and also wanted to rule out meningitis. So we thought of going ahead with MRI. So we went ahead with the MRI with angiogram, sir.
Okay, so you didn't have a high degree of suspicion for subarachnoid hemorrhage.
Yes, sir. At that point of time, we did not have.
And your CT brain is normal.
Yes.
Plain CT, non-contrast CT brain was normal. So,
Normal.
Because for that reason, we went for MRI.
Yes, sir. Yes.
What are the conditions wherein false negative CT scan will be there?
Like in subarachnoid hemorrhages,
Yes.
if presentation is late, sir, usually after 24 hours, the sensitivity goes down. So it will be difficult. And also perimesencephalic aneurysm bleeds, usually we will not find in CT scans. And
Yeah, if there is a small bleed or if the hematocrit of the patient is very less, even then it can be missed. As you told, it can be if it is prolonged, if it is delayed presentation also. Suppose if it is delayed presentation, what is the next investigation which is preferred if
Delayed
she's having severe headache?
Again, a CT cerebral angiogram should be done, sir, in case of high suspicion.
No, the thing is, question is clear. What he is asking is, if your delayed presentation and your initial CT is normal,
yes,
you have a high suspicion, you have a high degree of suspicion for a subarachnoid hemorrhage. What you should do?
Sir, MRI brain with flare
CSF,
and GRE.
How to confirm your
CSF.
diagnosis?
CSF, there is a xanthochromia, sir, due to breakdown of the RBCs. So that could be done, but nowadays rarely we do it, sir, because we go ahead with higher investigation.
So,
MRI with GRE and flare sequences can give an information of the bleed.
suppose patient presented to you within 6 hours, and the patient you have a high suspicion, but CT you have done. In the CT it is normal, no subarachnoid hemorrhage, but you have a clinical signs of clinical high suspicion for a subarachnoid hemorrhage. That time, will you go for CSF analysis?
No, sir. Within 6 hours, we can still go for CT cerebral angio.
So you should not go for CSF. At least you need to wait for how many hours to do CSF if you want to do?
At least not before 24 hours. Sir. Before 24 hours, we should not do.
At least you need to wait for 12 hours to look for xanthochromia. Suppose you want to take a decision by doing a CSF analysis, look for xanthochromia. So at least you need to wait for 12 hours.
Yes.
And MRI is when is the ideal time to go for MRI? Suppose
After
suspecting a clinical suspicion for a subarachnoid hemorrhage, your CT suppose CT is normal, but you have still have a strong suspicion. You have not done the CSF analysis.
after 6 to 12 hours after the presentation.
So usually MRI changes will not develop initially. So you need to what type of images in MRI sequences you need to see.
The GRE sequence you have to see. GRE and flare
you need
sequence.
to see. Yes. So for that, so if you do at least after 24 to 48 hours, if you do, the MRI pictures will be clarity, and then you have to look for GRE sequences for your diagnosis. Is there
Suppose,
yeah, please carry.
sorry for interruptions. You can continue, sir.
Yeah. Anything for city angio? Any indication for a city angio in this case?
So in high index of suspicion, where the initial CT scan, non-contrast CT is not suggest of any bleed, then we can go for CT cerebral angiography, sir. So it can give the vasculature picture as well as PC posterior circulation territory also can be clearly visualized.
And CT perfusion scan? Indication for any CT perfusion scan is necessary.
Fusion scans. In this case, if it is a subarachnoid hemorrhage, we don't usually go for.
So unless it's usually not indicated for to go for a CT perfusion scan. So CT angio, cerebral angio will go. But if you have any associated condition, means like associated means associated ischemic stroke, then in that case you go for CT angio. So that will helpful for a or patient later part of your in the suppose after time is delayed already 3 days 4 days happen, this patient already 2 days, but you have a string suspicion for a subarachnoid hemorrhage and you are expecting some complications, then that time you can go for a CT perfusion scan along with the CT angio.
Yes, sir.
Okay.
So grossly, if the patient presents with you with no neurological deficits, stable patient, if he is presenting with less than 6 hours, then CT scan is recommended. If it is negative, then we can treat as other causes of headache or migraine, all those things and all. Looking at the physical workup, all those things we have to do. If the patient presents with you with some seizures or neurological deficit of more than 6 hours, then if the CT is negative, then plan for LP CSF analysis. If look for the xanthochromics test with spectroscopic analysis and all. And usually these two will pick up almost sensitivity of those two will be very high. If the CT is negative, it will be picked up by the CSF analysis. MRI usually very rarely we do, and so yeah, go on.
And another investigation you have done, Silpa. Second, the previous slide, can you change the previous slide? Yeah. In the ECG, you have seen that T inversions in lead 1 and AVL and with the right bundle branch pattern. So, is it normal or abnormal finding, or what is relevance to this patient? And in the 2D also, you got that ejection fraction was around 40%, LVRWMA present with moderate LV dysfunction.
In case of SAH, sir, there will be a sudden catecholaminergic surgery can happen. This will have effect causing effect on the contractility and chronotropic and inotropic effect, which at later stages can present as a mimics of acute coronary syndrome, sir, in the form of lead changes in different leads, like T inversions, acuity prolongations, or some block pattern. And here the tropi positivity can be attributed to the catecholamine surge causing stress over the heart. And because of sudden sympathetic surge and catecholamine surge, it causing stress cardiomyopathy to the heart, causing regional, LV dysfunction in this patient.
Okay, suppose ECG, so you told that there are, you may see the QT prolongation, you may see T inversions, you may see ST depression, and you may see different blocks. So this type of ECG changes you may see in subarachnoid hemorrhage.
Yes, sir.
So, and patient may not be having a underlying coronary artery disease
Yes, sir.
in a subarachnoid hemorrhage.
Yes, sir.
So whether really patient is having underlying coronary artery disease or only patient is subarachnoid hemorrhage, from the ECG, can you differentiate in a acute coronary artery disease, coronary artery with subarachnoid hemorrhage? ECG changes, how will you differentiate ECG changes from the true coronary changes?
If it is a, I mean, there should be an ST depression or an ST elevation, sir, based upon the whether it's a end STEMI or a non-STEMI, and prior Q wave changes can indicate. Along with that, if it is an chronic changes, there will be definitely a P wave changes will be there, either increasing the height or width of the P waves. So this can indicate whether it is an acute event or happening in a previously with some underlying heart disease.
No, it is sometimes difficult to differentiate from an acute coronary syndrome, acute MI, from a subarachnoid hemorrhage, because ST depression or a T wave inversion you may be able to see in both conditions. But how to differentiate? Because the most common finding in subarachnoid hemorrhage you will see like QT prolongation. So with ST depression and T wave inversion, so maybe present in both finding, means both the conditions. But usually QT prolongation will be there in subarachnoid hemorrhage. In MI or coronary event, QT prolongation may be normal or it may not be, prolongation may not be there. And the T wave changes also, you have to see the pattern of T wave changes. So there are some specific T wave changes in subarachnoid hemorrhage and specific T wave changes in the MI. So usually, so tall means the T wave inversion like narrow and tented, tall tented T wave or a narrow T wave we will see in real MI. Whereas in subarachnoid hemorrhage, you may get a broad. So some few changes, but it's maybe difficult. So unless you do a coronary angio, if you have a high suspicion for a cardiac event along with subarachnoid hemorrhage, you need to go for an angio. In that situation, suppose you have a high suspicion for a coronary event and patient is having subarachnoid hemorrhage, antiplatelet you cannot give. So how to proceed about the patient? Suppose you have a high suspicion, you want to give antiplatelet, then how to proceed about the antiplatelets? The patient is with you, you are looking at ECG, and ECG are in favor of MI along with subarachnoid hemorrhage.
But any intracranial blood is a contraindication for antiplatelets or anticoagulants. So at this point of
That's
time,
true. I agree. You cannot give antiplatelet in presence of subarachnoid hemorrhage. Then how to proceed about it? Leave the patient like that.
Here, it is mainly due to the catecholamine surge, sir.
So
Yeah, he
it
answered
is
for
not
that.
due to ischemic event that we have to give a platelet at this point of time.
Yeah.
So we have to maintain the pain, we have to do the pain management properly, and so that her anxiety should come down, and then other hemodynamic support should be given rather than giving only the antiplatelets. If BP is going down, maybe we can support with inotropes. And,
No, that I agree with that. Those things you manage a part of those are management for subarachnoid hemorrhage.
yes, sir.
Along with that subarachnoid hemorrhage, you have some ECG changes which are in favor of acute coronary event.
Yes, sir.
So for that reason, patient needs an antiplatelet. So that situation, how to decide about that? So antiplatelet. So usually you should go for again, and first is your source. What is the etiology for subarachnoid hemorrhage? Suppose there is aneurysmal bleed. So you
Yes.
you go for aneurysmal that whether you are clipping or going for clipping or coiling. Then once you do the procedure, then you can start immediately antiplatelet. And then you can go for an angio, coronary angio. After going for coronary angio, you confirm your diagnosis, say that whether patient is having coronary CAD is there or not.
Yes.
If it is there, then you can, whether patient needs a stenting or whether patient needs only medical therapy, you can decide.
Yes.
That. Or you suppose the coronaries are normal, then you can stop the antiplatelet, not necessary.
Yes, sir.
And in your investigation list, you have written EEG.
Yes, sir.
One EEG. What is the role of EEG here?
Since she's drowsy and history of a seizure, we want to rule out any ongoing seizure activity, sir. So for that reason, we ordered EEG, sir. And because any further seizure episode will worsen the situation, like the risk of rebleed will be there. So though we have started on anti-platelet therapy, anti-epileptic therapy, we want to see the like effect of this anti-epileptic therapy. So for that reason, we are going ahead with EEGs.
Or anti-epileptic therapy is anyway it is any what are the means all cases of subarachnoid hemorrhage you consider for anti-epileptic therapy, or few case scenarios where you consider for anti-epileptic therapy?
Before clipping, sir, before clipping, we should go ahead, sir. Before clipping, we should go ahead with anti-epileptic, sir.
Before
After
the
clipping, if there are no recurrences, there is no need for continuing on the anti-epileptic therapy, sir.
Before securing of the aneurysm, another episode of seizure can further cause a rebleed. It can cause catastrophic events. In these patients, prophylactic seizures prophylactic anti-epileptic medication can be used. But after securing of the aneurysm, either by coiling or the clipping, we can, depending on the risk profile, we can stop the treatment. But if the patient has a seizures before securing of the aneurysm, we have to continue the anti-epileptic medications in these patients.
And at the same time, when you're assessing the severity of the patient's condition, your clinical severity and severity when you're assessing for in a case of subarachnoid hemorrhage. So in severe cases, patient is suppose on the scale, suppose more than 3, grade 3, suppose patient is presenting, or clinical, you are a World Federation and neurosurgeon, that also suppose presenting as a more than grade 3, suppose patient is presenting, and unexplained unconsciousness, and even after correction of your aneurysm repair, and patient is still not improving, clinical in that situation, you can go for an EEG for non-convulsive status.
Okay.
So look for any non-convulsive status. Okay. You can go ahead.
Any role of EEG in the delayed period? After 1 week or after 4 or 5 days? Since we are discussing about EEG.
Sir,
If there is a drop in sensorium, then we should consider, sir. But if the patient is improving and then after, as I said already, it is after clipping or after securing the aneurysm, then there is no need of continuing the anti-epileptic therapy.
Any new onset fall in GCS from the baseline status. So we have to exclude a seizure activity going on, sir. So in these patients, EEG need to be done.
Yeah, it can also detect the delayed cerebral ischemia also in case of SAH by the change of beta activity and all. In the delayed, not in the acute presentations. Okay, okay, go on. Now you have this patient who has a history of headache, and then you have diagnosed it as a subarachnoid hemorrhage. Based on the clinical history and the examination pattern, how will you explain the attenders? What is the prognosis? What could be the prognosis? How is the survival rate?
Based upon, there are two prognostic scalings, sir. One is World Federation of Neurosurgeons scale and another is Hunt and Hess grading. They divide into two grades, good grade and poor grade. Good grade is 1, 2, 3, where grade 1 it is a GCS of 15. Grade 2 is between GCS of 13 to 14 with no motor weakness. Grade 3 is 13 to 14 with weakness, whereas poor grade is grade 4 and grade 5. In grade 4, patient is having GCS of 7 to 12 in respect of motor deficits, and grade 5 is GCS between 3 to 6 irrespective of any motor deficits. So in grade 1, 2, and 3, that early securing of the aneurysm can have a good recovery. Whereas poor grade, we have to wait till there is a further improvement to the higher grade till to we proceed with the surgery.
How is the survival rates in this? Grade 4 and grade 5?
Grade 5, mortality is more than 50%.
So in grade 5, the survival is around 10%, but it was old studies and all. In grade 4, it is around 20%. 4, 5, 6, it is around 40, 50, 60 like that. Okay. So grade 1, grade 2 is having very good survival rates. Any other scaling systems you have?
Another is Hunt and Hess grading, sir. The Hunt and Hess grading, it is also given into 5 grades. In grade 1, she is asymptomatic or a mild headache. In grade 2, she has a moderate to severe headache. Grade 3, patient is having a confusion with cranial nerve involvement, with or without cranial nerve involvement, with some motor weakness. Whereas grade 4, patient is lethargic, and grade 5, it is a comatose state. And grade 4, grade 5 in this is a poor grade. And another is a radiological grading given by Fisher or modified Fisher. In the modified Fisher, grade 0, there is no SAH. Grade 1, there is a mild SAH with no intraventricular extension into either of the lateral ventricles. In grade 2, there is a thin SAH with intraventricular extension into the lateral ventricles. Grade 3 thick SAH without extension, and grade 4 is a grade 3 grade 4 it is a thick SAH with intraventricular extension. So total 5 grades in modified Fisher, sir. As the grading increases, risk of vasospasm and delayed cerebral ischemia are higher chances.
Okay, next slide.
So we have done a CT cerebral angiography in this patient, sir. So in this patient, it was suggested of the picture is showing involvement of the hyper intensities in the cisterns, basal cisterns, and anterior hemispheric and right Selvian fissure. Next slide. And this is showing in the interhemispheric and the Selvian fissures. Next slide. So this is a cerebral angiography. This is showing a wide neck sacral aneurysm arising from the anterior communicating artery 5 into 5 into 5 mm and absent A1 segment. Other vasculature were unremarkable. Next slide.
Based on the CT, can you diagnose whether it is an anterior circulation SAH or posterior circulation SAH?
It is an anterior circulation SAH, sir,
Mhm.
because
So,
it,
what are the bleeds which will have a high suspicion of anterior circulation, like?
sir, when the basal systems and the Sylvian fissure and interhemispheric, these are the systems when it is involved, it is indicating of MC and ACA territory involvement. So it
Hmm.
indicates a anterior circulation SAH.
Which is more common, anterior or posterior?
Anterior is most common.
In the anterior, which is most common site?
Anterior communicating artery is the most common site for this is the friction point where the chances of development of aneurysm is very high.
Okay, so the junction of ACOM and ACA, no? That is the most common site. In the posterior circulation, which is the most common site?
Posterior communicating artery in this most common site.
And proximal part of basilar artery, no? So proximal part of basilar artery. Okay. So here the aneurysm is in?
Yeah. And these are most, you told in your case, you got aneurysm, and suppose you don't get aneurysm. And what will be, so what person is having subarachnoid hemorrhage, so what you will do?
First, non-aneurysmal causes of SAH can be reasons, sir. One, we have to rule out a traumatic causes. Another is the AV malformations. And there is any patient having underlying systemic disorders, maybe due to a liver dysfunction or a renal dysfunction. And whether the patient is on any drugs such as antiplatelets or anticoagulants. So these are the causes of non-aneurysmal SAH causes has to be looked into.
Any other causes, important causes?
Mycotic aneurysms are secondary to any infections.
Mycotic aneurysm also comes under your aneurysmal bleed. Even AV malformation also, it comes under your AV malformation also sometimes, and dissection intracranial or intercerebral cranial internal, either vertebral artery or main basilar artery dissection. Sometimes it can, patient can have this one. Those are non-aneurysmal causes. Or CSVT also patient can present with this thing. And drug abusers, as you told, cocaine is one of the drug addicts. Rampantly some because if a young age, if you are getting very young age, non-hypertensive, and suppose 18 years, 20 years boy, something going to college and comes with a subarachnoid hemorrhage, CT is not showing an aneurysm, angio is not showing an aneurysm, you should have a high suspicion for a drug abuse. And anyway, we'll go for other evaluation also. Is there any management difference between aneurysmal SAH, non-aneurysmal SAH, or traumatic SAH? Because the presentation SAH will be, you can diagnose soon after doing a CT brain, you will diagnose. But is there any management difference?
So
Yes, sir. Like in the aneurysmal bleed, like aneurysmal SAH, we try to as early as possible, we'll try to secure the aneurysm because the chances of rebleed are up to 30%. So risk of further worsening in these cases will be more when compared to the traumatic, because once the trauma is taken out, then we should probably dealing with cerebral edema and other complications of bleed. But here the chance of rebleed and further worsening, like rapid worsening, is in our priorities. So it differs.
Yeah. And the second thing is, in your case, you got already aneurysm. Now, how will you manage this case?
Initially the airway and the circulation will be taken care, sir, and then I'll be taking care of her pain. She was complaining of severe headache, for which I was giving like 20 micrograms of like fentanyl aliquots because it was not subsiding with 650 mg of acetaminophen, which was we were giving at 6th hourly, and then we have started on anti-epileptics, and we even started her on injection mannitol as an anti-edema measure. And then we try to keep euvolumic, and though we have not supplemented any oxygen here, we should not allow her to go into hypoxia because she was drowsy, and we are not we are not supposed to increase allow hypercapnia, and any rise in temperature we should be closely monitoring, because these are all things will further worsen the ICP. And
Now, what was the indication for mannitol here? Why you have given mannitol?
Injection mannitol 1 gram was initially given because she was drowsy, and we thought we did not do ONSD at that time, and as an anti-edema measure we have given, so once it was
CT was also not suggestive of any
Sir?
any signs of raised intracranial tension, raised ICP.
Except for headache and that vomitings, we started on like antiemetic measures, but except for that too, no other signs we couldn't find.
So that should be proper indications for ICP.
Okay.
So how will you suspect that patient is having a raised ICP?
Raised ICP, the symptoms we have to look for, headache, nausea, vomiting, and neck pain, and any pupillary asymmetry we should look for, any papilla edema we should look for, and ONSD using ultrasound. And in case of any further drop in the conscious state, should alarm us like there is an ongoing rise in the ICP. And also on ultrasound, we can by using transcranial Doppler, where we can pulsatility index can be calculated, or increase in the mean flow velocity, which tells us about the vasospasm. Though on first day it is not so common, so we can go ahead with measuring the pulsatility index, which is the mean peak systolic minus end diastolic by mean flow velocity. If it is more than 1.19 centimeter per second, maybe we should consider that there is an raised ICP, and we should take the measures. That is one of the way. And if in the CT, or which we initially did, if there is an hydrocephalus features and then patient is symptomatic, maybe we should consider there is an ongoing ICP rise.
Any indication for ICP monitoring?
Indication for this case, there is a
For this case, anyway, patient is there are no features of ICP, so no need to monitor.
no need to monitor.
So,
We were monitoring
in a
closely.
subarachnoid hemorrhage, what is the indication for ICP monitoring?
Higher Fisher grades, grade 3 and above, where the thick SAH with intraventricular extension, where the chances of progression of hydrocephalus is high. So in these patients, we can go for an ICP monitoring, preferably an intraventricular catheter, which can act as more diagnostic as well as therapeutic.
No, sir, I disagree with this. We have evidence like a best trip, where there was a comparison between the invasive ICP monitoring versus the neurological and the close clinical manifestation, where there was no difference in the outcome. So I think we can go ahead with the close monitoring, and even in the severe grades with close monitoring, as well as with transcranial Doppler and ONSD techniques, and imaging like CT if feasible. We could even do same as that of invasive neuro monitor, ICP monitor.
No, definitely those patients who are having hydrocephalus. So if it will be kind of double purpose, so you can
Yes,
go for
definitely.
the external ventricular drainage, and you can monitor the ICP. Both can be done if patient is having hydrocephalus.
Yes, sir.
Both patients
agree.
who are Huntington has clinical grading is very high. For example, 4 or 5, GCS is low, and patients you want to monitor patients having signs of raised ICP, and there is an indication for ICP monitoring. So maybe close monitoring is required at that time. So indicates suppose you are able to monitor with the ONST, you are able to monitor by doing CT scans, you are able to monitor clinically, even though you do, but still it has a role for
in poorer grade patients where we plan for an intervention, so it can help in both therapeutic and diagnostic at initial stages, sir. Help in better prognostication also.
Okay. Next part of management.
Next slide.
Next part, management. You are talking about the management of subarachnoid. Your case, it is a aneurysmal SAH. Next, you told initially your pain management. So you wanted to give opiates. You wanted to give some
Anti-epileptics, anti-edema measure.
Anti-edema measures. Anything else?
Early securing of aneurysm has to be planned, sir. Since she comes in a better grade 2.
First,
grade
you have to
1.
answer that one actually. Yeah. So
Early
as
planning.
early as possible, you have to go for aneurysmal repair. Yeah. You want to go what type of method you want to go?
Here we have planned for surgical clippings.
Why?
When we discussed, they said like from after discussing with neurosurgeons, like the posterior SAH, like posterior artery involvement, then they are mostly amenable for the coiling when compared to the anterior ones. And again, considering into the advantages and disadvantages, like if you go ahead with clipping, where though it is an invasive procedure, but the chances of rebleeding are less. And when you consider the coiling, since it is not posterior and coiling, though it is minimally invasive, but the annual incidence of like rebleeds are more, and so that is a disadvantage, recurrence. And in this case,
How you decide means regarding whether you want for clipping or coiling. How you
again,
decide?
the size of the aneurysm at the neck. If it is a wide neck one, then we usually prefer to go ahead with the clipping, sir.
Wide neck sac ratio more than 1. So and difficult morphology. So and ruptured aneurysm. So these are the and anterior circulation. In this, we can go for clipping better than the coilings.
You have the DSA finding there?
No, sir. No, we have no, sir.
We only done CT cerebral
It's
angiogram.
several.
Then after that, any next step, aneurysmal, suppose you have went for clipping, then anything you need to do for management?
Yes, sir. Like we started her on nicardipine 60 mg 4th hourly tablet for neuroprotective measure in order to prevent the delayed cerebral ischemia.
When you started?
Like immediately, sir. Immediately we started, sir. After diagnosing subarachnoid hemorrhage, we started, sir.
Then anything else? How you want to monitor? Because monitoring is a part of the management. So this patient's subarachnoid hemorrhage, we went for clipping. How you want to monitor a patient's of subarachnoid hemorrhage?
One is the serial monitoring of GCS, sir. So and also any fall in the further fall in the GCS, we have to identify what might be the cause. Either it can be a rebleed, or it can be an hydrocephalus, or it can be a vasospasm, or it can be to delay cerebral ischemia, or it can be infectious. Any other than these medical complications, we have to identify. And then since she is already having a subarachnoid hemorrhage, so chances of vasospasm will be high. So and immediately we have to start on the nimodipine, and we have to maintain a target blood pressure before securing of the aneurysm. on a higher side to maintain the perfusion. Once the aneurysm has been secured, the BP targets can be reduced. So and we have to maintain a euvolumic status, euthermia status, and avoid hypoxia. And pain and agitation has to be addressed. At the same time, since she presented with the seizures, we have to proceed with the anti-epileptic medications.
Which anti-epileptic you want to do? You want to give?
Here we have started a levetiracetam, sir. 1 gram initially was given and then 500 mg BD was started.
Why not phenytoin?
Phenytoin is associated with hypotension. So more comfortable because here we try to avoid hypotension. We want to maintain even before clipping, maybe it is okay. But after clipping, we want to maintain with higher pressures.
So you told about nimodipine. Now, what is the role of nimodipine there?
Nimodipine, basically it's a neuroprotective agent, sir. Rather than it is preventing the vasospasm because vasospasm could be one of the mechanisms for the delayed cerebral ischemia, but there is an independent occurrence of delayed cerebral ischemia also. So it is shown that the outcomes neurological outcomes are better and and by preventing the delayed cerebral ischemia.
Okay, so you are giving as a prophylaxis for the to prevent delayed cerebral ischemia.
Yes.
What are the risk factors wherein which type of patients will be more prone for delayed cerebral ischemia? Vasospasm.
The patients with intraventricular extension, more the extension blood in the ventricles are more chance that they may go ahead and they may have delayed cerebral ischemia. The chances are more with them.
Here the Fisher grade more is the risk, sir. As the Fisher grade increases, the chance of vasospasm and consequently delayed cerebral ischemia risk increases. May go up to 45% at the rate of grade 4.
And anemia patients are also more prone for delayed cerebral ischemia.
Anemia patient and any dyselectrolytemia during this period also to be taken care, and hyperglycemia also associated with the delayed cerebral ischemia along with that.
When will you start seeing delayed vasospasm and when will be the peak?
4 to 14 days. Usually 4 to 14 days is the time period where the vasospasm is likely to.
3 to 4 days it will start and peak around 6 to 8 days like that. And it can go up to 14 days. How will you monitor that?
Conscious state is the best thing to assess what is her baseline, and then daily monitoring hourly if possible. The conscious state will tell us if she's having any drop in GCS, and we should.
If the patient is in conscious state, sir, then the serial clinical examination will give a clue. If the patient is in an unconscious state, then the serial transcranial Doppler monitoring along with ONSD can give a clue of ongoing vasospasm with raised ICP.
In case of mild vasospasm, like more than 25%, then we will have the mean mean flow velocities will be corresponding mean flow velocities will be there. So normally 120, if it is 120 to 140, then if it is more than 50% of the spasm, then more than 190. If in case of severe spasm, then we will find the mean flow velocities more than 200 centimeters per second. So
that is wrong actually. What you are telling.
Along with the Lindigard ratio, we should use it.
1 second.
Yes.
So if the is conscious, monitoring the transcranial Doppler is very important because TCD will pick up the vasospasm almost 24 to 48 hours prior to the neurological deficit. That is wherein you have to pick that, and then once the neurological deficit sets in, we have to address with an intervention there. Okay, so serial monitoring, taking the baseline value of mean flow velocity, and then serially daily monitoring, and if there is a worsening of the GCS or neurological deficit, then twice a day or thrice a day based on that. And if there is a serial increase, then you alarm the interventional radiologist and then keep in the loop. If there is a starting of neurological deficit, that is wherein you have to introduce what medications you'll use, what are the intervention you will do if there is a vasospasm?
This is actually usually done by the interventional radiologist, sir, where we can directly inject the vasodilating agents like papaverine or milrinone or other agents like nicardipine and also verapamil. But we have seen doing with milrinone and papaverines, most commonly papaverine.
Nimodipine, intra-arterial nimodipine has shown very good benefit. Usually they will use intra-arterial into the MCA or ACA, wherever the spasm is. They will inject nimodipine 0.5 to 1 milligram. After that, if it is persisting, then papaverine, usually papaverine will be used in the intraoperative period where they will clip, no? If there is a vasospasm, directly they will inject into that. And the people do use papaverine during that injection, and milrinone also study from NIMHANS has shown very good benefit. And milrinone infusion we use for preventing and treatment of vasospasm. Nimodipine dosage for prophylaxis is completely different from the therapeutic dosage. And for prophylaxis, we use on the day of diagnosis 60 milligram 4th hourly as a tablet. For milrinone at a high dose, we'll use as an infusion for treating vasospasm. If there is a continuous hypotension or something like that, we can use noradrenaline along with that. But continue milrinone so that it will address nicely. And then the neurological deficit, even if there is a infarct in the MRI also, slowly it will improve. Complete recovery will be there for the patient. And if required, if the spasm is increasing, if you are not able to break the spasm, we can repeat the intervention by giving the injection and all. There are many other interventions like stenting, all those things and all that. It's we can discuss it later. So apart from this,
this is important actually. It's because hardly will see, as you told, Dr. Ramesh told, that hardly will see means the signs and symptoms of vasospasm will be late. Neurological symptoms will be later. Patient might be having a radiological vasospasm, and patient neurological signs and symptoms will be late or may not be there, because hardly will see 30 to 40% cases. But whereas 60% cases you will see radiological vasospasm. So for that reason, a close monitoring with the interval CT NGOs also will be helpful. Whenever there is a high degree of suspicion, we should go for a DSA. And once you confirm your diagnosis that significant vasospasm, high risk for a DCI, then that time definitely you should go for a vasodilator agent, or a stenting. Sometimes the stenting, if required, you can go for stenting also.
so how will you differentiate in transcranial Doppler a case of subarachnoid hemorrhage going for vasospasm compared to hyperemia? Both will have high flow velocities, high mean flow velocities.
Yeah, that is when we have to comprehensively look with the Lindegaard ratio, sir. Lindegaard ratio is the, sir?
What is that?
Lindegaard ratio is the Lindegaard ratio, sir. Lindegaard ratio is the ratio between the mean flow velocities in the middle cerebral artery by the extracranial part of the internal carotid artery. So if that ratio usually 1 to 2 is the normal, sir, more than 2 is abnormal, sir, and more than 6 is severe spasm, sir. And between 3 to 6, it is again moderate. Sir.
Yeah, 2 to 3, it can be mild spasm with hyperemia. If it is more than 4, 5, 6 and all, it will be more of vasospasm, moderate to severe vasospasm. Is the mean flow velocity grading what you told more than 120 of middle cerebral artery anterior circulation is same as the posterior circulation, or is it different?
Inflow velocity.
For diagnosing a vasospasm in the posterior circulation, do you use the same value of 120 of mean flow velocity? No, there it
This
is
is middle cerebral artery, sir. So definitely it should be different, sir.
Yeah, so in the anterior circulation, mean flow velocity of more than 120 is significant. In the posterior circulation, mean flow velocity of more than 70 is significant. So there SVRI ratio will come. And if it is more than 2, that is considered as spasm in the posterior circulation. Okay. Okay. So you told about DSA, no? What is the role of DSA in subarachnoid hemorrhage?
The DSA is considered as a gold standard for like diagnosing it and also for the treatment endovascular coiling. And usually despite doing a CT cerebral angio, sometimes we miss subarachnoid aneurysms. So it is always better to go ahead in case of high suspicion to go for a digital subtraction angiogram. If you're still suspicion, maybe we may have to repeat it also in the later date.
So yeah, it is both diagnostic and therapeutic, and it is considered as a gold standard for planning the management of subarachnoid hemorrhage. And we can know the size of the aneurysm, whether the rupture is there or not, neck, what is the location of the aneurysm, and then what is the size of the neck also, which is more important for planning of coiling or clipping or something like that. So we can plan the management based on that, according to the ISAT and BRAT data analysis. No, anterior circulation, as you told, it is more, we can go for clipping, and posterior circulation more for coiling. Basilar artery aneurysm is more amenable for coiling. It is very easy for coiling for them compared to middle cerebral artery. And if the patient is having a large intracerebral bleed with an aneurysm, then more probably surgical option is better with the decompressive craniotomy, and then the clipping we can opt. And if there is hydrocephalus associated, then do the surgery with the ventriculoperitoneal shunt or the AVD to monitor the blood pressure. And so as you told, the wide neck and all, surgical option is better than the small neck. But whatever it is, the intervention, it's better to be done within 24 hours as early as possible because of the risk of free bleeding. When is the risk of free bleeding more, like how is the pattern of free bleeding?
Within 24 hours, there is high risk, sir. 4% of 4 to 10% they have chances of high rebleeding. As the days increases, the chances will be 1 to 2% per day per week.
Okay.
So
Is there
another control of the blood pressure is also important. Suppose the patient's blood pressure is very high, so you need to control the blood pressure.
Yes.
How will you manage blood pressure? What is your target blood pressure?
Before securing of the aneurysm, sir, we can accept a blood pressure of 160 by 90 to 100. After securing of before securing of the aneurysm, we should reduce the blood pressure up to 140 by 90. Because we have to maintain the adequate perfusion in respect to the ICP, and after the securing of the aneurysm, to counteract the expected vasospasm, we have to target a bit higher blood pressure of 160 by 90 to 100. And high blood pressures can be managed by beta blockers like labetalol. 5 to 10 mg, which can be repeated over 5 to 10 minutes, and other one are esmolar, and other are calcium channel blockers can be used.
What calcium channel blockers you prefer?
Nicardipine.
In emergency, it is hydrolyzine, sir, 20 mg every 10 minutes. We can.
Any precautions for hydrolyzine?
Sir,
Any precautions for hydrolyzine? Before giving hydrolyzine, any precautions?
Yeah.
If the patient is having underlying coronary artery disease, it should be avoided hydrolyzing. And second, why don't you consider for NTG or nitroglycerin?
It causes it increases the cerebral blood flow, which can cause further bleeding and raised cerebral edema and raised ICP, sir, which again further compromises the cerebral perfusion pressure.
Any role of tranexamic acid?
Sir, before securing of the aneurysm, the tranexamic acid can be used, so the studies are inconclusive.
Which trial was that?
Trial they have done, sir. But previously, the time frame going for the surgery was bit delayed. But as per the current recommendations, within 24 hours in a good grade, we have to priority should be the securing of the aneurysm.
The role of steroids?
No, sir.
No, sir.
Any role of fludrocortisone or mineralocorticoids?
These patients are prone for hyponatremia, sir. If it is secondary to the cerebral salt wasting, in those patients, the fludrocortisone has a role.
So this patient recovered from the acute episode. You did the clipping, and she went to ward. After 3-4 days, she had presented with you with altered sensorium. How will you evaluate?
Mm.
First, the vasospasm and delayed cerebral ischemia has to be identified by imaging, sir, either by plain CT or a CT angiography. Second, other causes can be rebleed or development of the hydrocephalus. Another reason can be an infection, and another can be an electrolyte disorder, sir, either hyponatremia or dysglycemia. These are the most common things. And secondary, it can be an infectant focus anywhere in the body, and a non-infectious causes of the fever can also has to be evaluated. So these are the things first we have to evaluate and proceed accordingly. So
Can
first
the patient-
suspicion will be always a delayed cerebral ischemia.
Okay. Can the patient has can they present with rebleed after clipping and coiling also?
Yes, sir. If another aneurysm is there and which we have missed, then the probability is also there. That unlikely, and
The patient has proceeded with endovascular coiling. There can be a
Is
migration
less
of the
than
coil.
1%. Chances of rebleeding is less than 1%.
0.6 to 1% is incidence of rebleeding in after post coiling and clipping and all. So hydrocephalus also you should keep in the differential diagnosis, because the intraventricular hemorrhage can go for hydrocephalus. They can also present with some altered sensorium and delayed this one and all. Okay, as you told, infection, all those things and all, you have to evaluate. If the patient is having sodium of 121, how will you manage?
here the sodium, the dyselectrolytemia in these subarachnoid cases, it should be due to this due to humoral and neuronal like disturbances. So either it could be SIDH or it could be in a cerebral salt wasting syndrome. So if it is in cerebral salt wasting syndrome, maybe we should consider giving fluids and 6th hourly or 4th hourly monitoring of the serum sodium. If it is an SADH, then we should restrict the fluid and then close monitoring of the sodium. Despite if where we are not able to give, maybe we should consider tolvectins.
How will you differentiate between those two?
Sir, the serum osmolality, both are true hyponatremia, sir. So the serum osmolality is less in both, and urine osmolality is more in hyperosmolar in both. And the main differentiating feature is it is euvolemia in SIDH and it is hypovolemia in cerebral salt wasting syndrome. And one more differentiating feature is fractional excretion of the uric acid after correction of the hyponatremia is it will become normal in case of SIDH, but it is still elevated in case of cerebral salt wasting syndrome. So only after correction, I think we will know. For me, as far as I know.
Okay.
Role of any infrared spectroscopy?
These are the advanced neuromonitoring techniques, sir. So whenever there is a vasospasm is happening in that area of the involvement of the brain, there can be a decreased perfusion can happen, and this near infrared spectroscopy can identify the difference in the spectrum, different changes. So this can give a clue, or like the ischemic penumbra part we can identify and we can intervene.
Okay. So what are the bad prognostic markers for a subarachnoid hemorrhage? Poor prognostic markers for a subarachnoid hemorrhage.
Higher
Elderly,
rates.
elderly age of the presentation, sir. Wide neck aneurysms and higher Fisher grade at the time of presentation, and poor GCS at the time of presentations. So these are the poor prognostication factors.
With a high intraventricular extension, higher volume of intraventricular extension.
Fisher grade.
Or if patient is having a rebleeding within 72 hours, that is also high risk for this. Or patient is developing a DCI, means delayed cerebral ischemia, severe vasospasm and DCI. Suppose patient develops, that is also a poor prognostic marker, because the patient develops ischemic event and with a neurological deficit secondary to DCI, then that is also poor prognostic marker. That's what. So these signs are there, then because you need to prognosticate the patient. Dr. Ramesh first asked you that you need to prognosticate the patient depending on the clinical status and anticipating the complications. So we need to know what the patient is having and what is your expectation, chances of recovery. So then accordingly you can prognosticate the patient.
So since we are discussing about delayed cerebral ischemia, any role of triple S therapy? What is the role of triple S therapy in prophylactic triple S therapy and therapeutic triple S therapy? Anything is there? Any role is there?
No, sir, it is nowadays we are not following triple H therapy because it is leading to more of a cardiopulmonary complications. Already a patient will have this like a neurogenic pulmonary edema and neurogenic stunned myocardium. So where it will further complicate the patients. So nowadays we are targeting at euvolemia, and we're not going for triple H.
But we should always avoid hypovolemia. We have to maintain the patient in euvolemia. And the BP target, how we should keep in delayed cerebral ischemia or vasospasm. In that 1H, we are still following, no?
Yes, sir. Yes, sir.
Sir, if we are able to maintain her baseline blood pressure and without any vasospasm features or delayed cerebral ischemia, then we can maintain that blood pressure, sir. If there is a patient has developed any features of focal deficit secondary to vasospasm, then we can go up to 160/80, and even if the symptoms are still persisting, we can go up to 200 by systolic blood pressure of 200. If there is no end organ dysfunction due to the hypertension, we can go up to systolic blood pressure of 200. Till we decrease the symptoms of focal symptoms. Meanwhile, we have to plan for the DSA procedure with intra-arterial drugs such as papaverine or milrinone or nimodipine, if feasible, with angioplasty. I mean, with angioplasty.
To maintain, usually we give vasopressor support, sir. But despite that, we'll continue 60 mg the 4th hourly. So at least for 21 days. For that reason, we will.
No, Silpa, means if suppose somebody is requiring a NORAD support to maintain the blood pressure, that time you need to reduce the dose of nimodipine. Means you can frequency you can increase. Like instead of 4th hourly, you can go for 2nd hourly. Make it 30 mg. Yeah, 30 mg 2nd hourly you can go. Suppose NORAD requirement is not there, you can continue with 60 mg 4th hourly. If NORAD requirement is there, better to you decrease the dose and increase the frequency.
Yes.
Any role of brain specific biomarkers?
One is neuron specific sir. Another is cerebral microdialysis. We use a lactate pyruvate ratio. So the lactate pyruvate ratio will indicate whether is happening any anaerobic metabolism due to focal ischemia in those patients. So these are the two things where we can use to know the regional cerebral perfusion and metabolism happening in the area of the vasospastic area of the brain.
The other advanced oxygenation parameters like brain parenchymal tissue oxygenation, which should not be less than 20, and again the jugular oxygen saturation, which we should target above 55. So if it is less than 55, again more chance of ischemia. If it is available, we should.
When will you start DVT prophylaxis, and what type of DVT prophylaxis we use?
If the patient is going for coiling, then actually in this patient, intermittent pneumatic compression stockings we applied on day 1, sir. And if we are going for endovascular coiling, after discussing with the surgeons, then on the day we can start according to the evidence. If it is going for the clipping, after 3rd day we can discuss with the surgeon and then go.
Sequential compression device initially, mechanical compression device, and then we can go for
Foam coiling.
okay. So any role of that stents, diverters you heard of?
Yes, sir. When a large aneurysm is involved in these patients, the flow diverters can be used, sir. And another is the balloon devices can be used for diverting this.
Now, what is the problem with that? Why we are not routinely using that?
Chances of rupture.
So chance of rebleeding is also more, and then the chance of blockage, stent thrombosis and all is more. It is more thrombogenic and all. And we have to continue antiplatelet therapy. Once we insert that stent, we have to continue the antiplatelet, dual antiplatelet therapy. We have to continue. Okay. I think.
Yeah. So, yeah, I think you have anything further. What happened to your patient? Can you just summarize your findings, Silpa?
She her till day 5 she was fine, sir. On day 2, day 1 we have taken for the surgery, day 2 we could extubate her, and then day 5 she had a new onset fever, and then her sensorium has become little drowsy. So then we have repeated MRI. So focal diffuse weighted image restriction was there, but there was no significant drop in the sensorium. But her fever spikes, once it is being subsided, then her sensorium was daily getting better. Like around by day 8, it was better. The foci, what we found was we have changed the Foley catheter and then sent the cultures where we could culture Eclipsella, which was drug resistant, and we started her on colistin, and then she was eventually improved. So on day 8 we could shift out of ICU, and then by day 12 she was discharged.
Okay, so cause for deterioration in the sensorium in between was due to infection here in your case.
She also had lateral rectus palsy on the left eye, sir. She was not able to abduct. So that is when they even thought we should go ahead with MRI. So they repeated
Then you could find any cause for lateral rectal palsy?
No, sir. No, sir. No significant changes. The MRI, repeat MRI, we could not find.
So no compression of the sixth cranial now?
No, sir.
When the compression will occur for sixth cranial now?
Yeah.
In posterior circulation aneurysms, these are most common.
And rise, if there is a rise CT also, the sixth nerve will get.
Pseudo-localizing.
Yeah.
It was a good presentation. So I think it's important topic actually. It comes in the exams for anyone. This And so many complicated things also we'll see. It is basically this case. In this case scenario, you found that initially patient presentation clinical severity was less, and the patient was clinically stable. You could diagnose. Patient presented after 2 days to the hospital, and with MRI you confirm you had a diagnosis. And then after that you went for clipping, and the patient has improved significantly without any complications. But there are so many scenarios we'll see different complications in subarachnoid hemorrhage. So we need to remember how to monitor the patients, what to look for. So like whether is risk for any rebleeding, risk for any vasospasm, risk for any hydrocephalus, risk for any DCI, so risk for any electrolyte imbalances or metabolic complications, any other things you need to look for to monitor the patients. And accordingly, as early as possible, we need to stabilize the patient. That is our main protocol for managing the subarachnoid hemorrhage cases. So,
yeah, sir. Yeah. So there are a couple of questions, sir. Basically, if the patient who is on antiplatelets or oral anticoagulants, if they develop SAH, what is your approach to management other than the whatever we discussed?
yeah. So basically, if a patient is on antiplatelets, we need to withhold the antiplatelet at that point of time, and we need to identify if there is aneurysm, aneurysmal SAH. So first we have to aneurysmal, we have to close the aneurysm either by clipping or coiling. So once it is done, again you can restart the antiplatelet, whatever the indication, whether it is underlying MI or whatever the indication, we need to continue the antiplatelet. So anticoagulant also, it is the same scenario for the anticoagulant too, and we need to monitor for the coagulation parameters also too at that point of time. So otherwise, no specific treatment, no need to give any like platelet transfusion. Those things are not indicated.
Yes, sir. If there is if the patient is on warfarin and very high elevated INR,
Yeah.
your anticoagulants, and there is in the context of bleeding intracranially like subarachnoid hemorrhage. So, is there any role of going for the prothrombin complex concentrate initially to not to worsen further the bleeding and all? So, probably in the context of maybe very poor grade SH and all, maybe initially to reverse whatever the anticoagulant effect.
Yeah. So
Yeah. Any thoughts, sir?
Yeah. So we can give a 4-factor PCC because INR is, so if usually if your target INR you want to keep between 2 to 3, and if it is more than 3, suppose more than 5, usually, so definitely there is an indication for a 4-factor PCC, and between 3 to 5 also you don't consider unless patient condition is worsening. So more than 5, definitely there is an indication for 4-factor PCC. And yeah.
Yes. So, what are the cardiac complications that can be possibly associated with SH, severe SH? That's what one question, sir.
Yeah, cardiac complications usually they present with mostly they will present with like QT prolongation and other ST depression, T-wave inversion, different arrhythmias or ventricular premature complexes, this type of ECG changes. Coronary events, even so many studies also there. It was published also that the simultaneous with subarachnoid hemorrhage coronary events are acute coronary events are less. But to rule out, when you have a high suspicion, patient have some typical chest pain, underlying diabetes or some other comorbid conditions are there, and ECG changes are typical, you have a high suspicion, then that time you need to go for an angio to go confirm your diagnosis.
Yes, sir. There is another question from Prashant. So, patient with SH with ACS, MI simultaneously, both are having, so he's having, but couldn't find any cause like aneurysm from DSA to clip or coil. What to do at this time? Antiplatelets or angio?
No, I could not get. Suppose both are there, good coronary
Both
syndrome and plus SAH is there. But SAH, there is no aneurysm, you are saying, no?
Yeah, that's what he asked actually, but
Okay.
it's unlikely. I feel.
Yeah. Suppose if SAH aneurysm is not there, so you are not able to clip if you don't find any cause, it is a non-aneurysmal management.
Yes.
And you suppose you search for whatever the cause for why it has happened, whether it is a traumatic or something. So at that point of time, the person neurological status is stabilized for at least 48 to 72 hours. And you can consider for a antiplatelet and simultaneous evaluation for an angiogram, coronary angio, to look for patient is having a blockage is there or not. If no blockage, no need for antiplatelet.
Yes, sir. Yes, sir. I think simultaneously having ACS and SAH, definitely it's a difficult scenario and difficult to manage case basically. Okay. Next, otherwise, no other questions, sir. I think there is another question which is how to manage SAH secondary to DAVF, that is dural, I think arteriovenous fistula. I think it's mostly because of some venous hypertension and all, but otherwise nothing much. Only they manage symptomatically in these patients, not much of any.
Usually happens in the spinal cord actually. In the spinal cord, usually they go for surgery only.
Yes, sir. I think with this, I think we are coming to the conclusion of the session. I think it was a well elaborate discussion happened. I think from all angles, both Prusty sir and Dr. Ramesh both totally covered everything. I think most of the students get benefited with this session. So thank you very much, sir, for both of you, Dr. Saroj Prusty sir and Dr. Ramesh, for coming on board to and hosting this session. So I thank Dr. Srikanth and Shilpa, Dr. Shilpa for bringing out this case, which is really all angles it almost touched, and you, I think, answered very well across all questions. So thank you very much, sir. I think with this we'll conclude the session. Any final remarks you want, Ramesh or Prusty sir? Please go ahead.
Thank you, Venkat sir. Thank you, Kaladhar. They have presented very well. Only thing for as an intensivist, early we have to diagnose SAH early and push for intervention as early as possible. And then knowing the complication, we have to keep on monitoring for the complications, not waiting for the neurological deficit to develop. Early addressing the complication early is always better. Thank you. Thank you, sir.
Yeah, thank you. Thank you, Dr. Kaladhar, Dr. Venkat, for giving opportunity. For it was a good case discussion, and Dr. Srikanth and Shilpa both presented well, and I think it was a good discussion. Thank you, Dr. Ramesh also.
Thank you, sir. So we conclude the session. Good night, friends. I think keep listening to our master classes. Thank you.
Yeah.